Topic is simulation in anesthesia. Shall I start?
Yeah, where are you from? Rahul Katyal?
I am from Northern Railway Central Hospital, New Delhi.
Okay, okay, right. Go ahead.
Simulation allows personnel to practice and learn principles in a controlled environment that will better prepare them for the safe administration of healthcare to patients. It is a potential way of learning and practicing all the skill without harm to the real patient. It can be a part of organization's patient safety strategy and support building a culture of safety. The obstacles to providing simulation training are that obtaining access to the learner population for the requisite time and providing appropriately trained and skilled simulation instructors to prepare, conduct, debrief, and evaluate the simulation session. There is a Miller's pyramid of learning, four different competence based on four different competence level. It can be divided into a theory and a practice part. The most relevant clinical competence is the real-time performance. Those four levels need to be considered when addressing learning goals as well as assessment goals of the simulation. And some part of the history is that medical simulators were introduced in the early 1960s in the form of mannequins designed to aid in teaching mouth-to-mouth resuscitation. The Ambu Man by Henning Rubin. The first computer controlled simulators were seen in the mid 1960s. Impetus for the development of simulators came from the observed pallors found in the aviation industry. Similar to the aviation environment, medical practice in the operation theater ICU casualty involved multiple tasks requiring high degree of vigilance, procedural monitoring, and decision making skills in a dynamic, complex environment which is affected by the simultaneous interaction of the different members of the operative team. As in aviation, critical life threatening incidents are rare, but when they do occur, they have potential disastrous consequences unless the doctor is able to quickly diagnose and correct the problems. The advantages of simulation is that there is a high degree of they can simulate a high degree of reality. There is no risk for a real patient, and tasks and scenarios can be created to demand. Skills can be practiced repeatedly, and it allows for practice on clinically rare scenarios also. Videotaping can also be done for the scenarios which can be reviewed later on. Simulation can be stopped and restarted for teaching purpose also. Transfer of training from classroom to real situation is enhanced. The objectives of the simulation is that education and training of technical and non-technical skills, system probing, testing of equipment and supplies, assessment, evaluation, research, and other purposes. Simulator fidelity. Fidelity is the extent to which the appearance and behavior of a simulator and the simulation matches the appearance and behavior of a simulated system. The level of fidelity required depends on the type of task and the stage of training and the influences on the skills transfer. Simulators are typically described as low, intermediate, or high fidelity based on their this attribute. Fidelity could be physical fidelity, environmental, equipmental, or psychological fidelity. So the classification of simulators can be part task trainers, computer-based systems, virtual reality and haptic systems, simulated patients, simulated environments, integrated simulators. So the part task trainers in this the trainers are designed to replicate only a part of the environment. They will often resemble anatomical areas of the body Examples, the module used to train basic skills such as intubation or venipuncture. They are the advantage is that they are relatively inexpensive. The computer-based systems can be used to model aspects of human physiology or pharmacology, simulated task or environments, and allow interaction with this through a computer interface. The main focus of learning is on using information to make treatment decisions. This system can provide the student with feedback, which allows for independent learning. The advantage is that they are relatively inexpensive. Then the virtual reality systems. Virtual reality is the ultimate computer-based technology. Its main aim is to present virtual objects or environments to all human senses in a way which is identical to the natural counterpart. And sir, simulated patient and environment systems. The simulated patients are the highest fidelity simulator. However, their use is mainly restricted to the teaching of communication and interpersonal skills. Simulated environment. This involves recreating the working environment in which multidisciplinary teams can work together, like the operating room. This gives an opportunity for learners to examine their roles within a team. Then the integrated simulators, the combined part or the whole body mannequins on which to carry out information interventions with computers, which drive the mannequin to produce physical signs and feed physiological signal to the monitor. Example is the medical education technologies, METI, Human Patient Simulator, HPS. Then, sir, the model-driven simulators make the dynamic interaction and feedback less operator-dependent. Hence, more complex scenario can be undertaken. Due to their complexity, model-driven simulators are very costly, both in terms of purchase and running cost. Then, sir, screen-based simulators. They run on a computer with no additional hardware. Users interact with it through conventional devices such as keyboard or mouse. They are good devices to acquire technical skills. The advantage of a screen-based simulator is that they are low cost, more readily be used by a trainee alone without the need of a tutor or actors, which also reduces the cost. Disadvantage is that they cannot be used to practice psychomotor skills or teamwork. Then, sir, hardware-based simulators. Uh, they are also called mannequin-based simulators. Trainees interact in much the same way as they would interact with the real patient. The control logic is manipulated through instructor or operator station that allows the instructor to create specific patients, select and implement abnormal events and faults, and they monitor the progress of the simulation session. It is common to obtain detailed records of the simulation and action taken from video and audio recording of the personnel working in the replicated clinical environment. It provide better training for behavioral aspects of crisis management, such as communication, leadership, and interpersonal conflicts. Usually required more space as well as other equipment such as anesthesia machines and defib. The ongoing costs such as repairs and maintenance are therefore higher. Then there are virtual reality simulators. It refers to a set of techniques in which one interacts with a synthetic environment that exists solely in the computer. Using virtual reality, parts or all of the patient and environment are presented to the user by three-dimensional representation with or without touch to create a more immersive experience. A screen only simulator could be viewed as a very limited virtual reality simulator. The currently used mannequin-based high fidelity simulator systems, they can be used to simulate the airway, where we can see the appropriate pharyngeal, glottic, and bronchial anatomy. We can use it for placement of face mask, ET tube, LMA, combi tube, and it can also simulate laryngospasm, tongue and airway swelling, cervical immobility, jaw closure, breakable teeth. We can use it for cricothyrotomy, transtracheal jet ventilation. For the head part, we can use it to see the effects of drug on the pupil or the reaction to light and medication. Patient voice and sound such as coughing and vomiting through an inbuilt loudspeaker. We can see the we can touch the carotid and feel the pulses. Cyanosis can be simulated by blue light. Tearing can be produced in the chest. Physiological or pathophysiological heart sound and breath sounds can be produced. Spontaneous breathing with chest wall movement can be done. Bronchospasm can be done. Then the pulmonary compliance and the airway resistance can be simulated. It can also simulate pneumothorax. We can use it to do a needle thoracotomy, and chest tube placement can be done. We can use it for defibrillation, transthoracic pacing, chest compressions, and using the simulators, monitoring can also be done, like the ECG, SpO2, invasive blood pressure, CVP, PAP, cardiac output, temperature, CO2, anesthetic, gas. We can see the actual uptake and distribution of the agents. And sir, based on the site of simulation, it can be divided into the dedicated centers where the only the center is dedicated for the purpose of simulation, or it can be a temporary in situ simulation where the actual it is a actual work unit, but the temporary setup can be made. In the dedicated center, it is difficult for a person to leave his workplace, and he or she has to take time, and they are also very costly. For the temporary in situ simulation, the actual workplace, we have to find a bigger space to set up the things, and it is very costly. So it can also be a residential in situ simulator. It is same as the temporary in situ, and easy in scheduling the meetings, but it is also high cost. Then sir, mobile simulation can be there, but the cost is very high for making a mobile simulation also. And sir, the conclusion is that simulation is an educational technique that allows interactive activity by recreating all or part of the clinical experience without exposing patient to the associated risks. Many applications have been found for simulation in medical fields, including teaching and training, evaluation, and research. Most important component of high fidelity patient simulation training is the self-reflected debriefing session after the clinical scenario. Crisis management, resource management can also be trained. So
So
thank
that
you.
is too much of an elaborate answer for the question which you cannot finish, I think, within the 20 minutes that is available for you. Okay? So that can be made more concise, and I think you need not waste time writing each and every procedure that can be learned by doing the simulation training. Okay? So
Yeah.
that part